2 days events so far. And I'm very happy to say that we have had very positive feedback regarding the lectures from the 4 eminent speakers. And I'm sure the following few days as well, we have, this will add more feedback to this particular event. So today, to kickstart the events, I'll call upon Dr. Karthikeyan, Professor, Department of Conservative Dentistry and Endodontics, SRMDC College, to start the proceedings.
Thank you, ma'am. Good morning, one and all. The topic for today's first lecture is custom cast post and core for your eyes only. I request Dr. Ramya Raghu, ma'am, Professor and Head, Department of Conservative Dentistry and Endodontics, Bangalore Institute of Dental Sciences, to chair this session and to introduce the speaker of this session, Dr. GIRIJA Sajjan, ma'am. Over to you, ma'am.
Yeah, thank you, Dr. Karthikeyan. A very good morning to all the participants for today's program. First of all, let me thank Dr. Mahalakshmi, Dr. Rajkumar, and their entire team for conceptualizing this program, this wonderful initiative of training the trainers under the banner of IACDE, which will bring about a lot of uniformity in our postgraduate curriculum as well as our postgraduate programs across the country. And I'm extremely glad that I'm here to moderate the session that is being presented by Dr. GIRIJA Sajjan. Dr. GIRIJA Sajjan is a well-known academician and accomplished clinician. I don't think she needs much of an introduction, but I'll just provide a short introduction to Dr. GIRIJA. She completed her BDS from KLE Dental College, and she secured the Best Outgoing Student Award from the college. She completed her master's from Bapuji Dental College, Davangere, and presently she is the professor and head of the Department of Conservative Dentistry and Endodontics at Vishnu Dental College, Bhimavaram. She has over 25 years of undergraduate and postgraduate training experience, and she has guided about 50 postgraduate research projects. She has 54 national and international publications, and she has also authored a textbook. Presently, she's heading the department at Vishnu Dental College. She has presented various guest lectures in different states of India. She has been trained in microscopic dentistry and is a course director of the Academy of Microscopic Dentistry, Vishnu Dental College. She is a member and chairman of the Board of Studies Post-Graduation at Dr. NTR University of Health Sciences, Vijayawada, and her main areas of interest include nanodentistry, microdentistry, aesthetic dentistry, and regenerative dentistry. She is going to give us an overview on cast, post, and core, which is the first practical exercise for PG examination. Over to you, Dr. GIRIJA.
Thank you so much, Dr. Ramya. It was a very kind words from you about me, and I'm extremely happy to be a part of this FDP program. And then now we will just see our presentation. Thank you so much. Not able to hear.
One minute, just 1 minute.
Endodontics. Custom. Namaste. Good afternoon, everyone. Myself, Dr. GIRIJA Sajjan from Vishnu Dental College, take immense pleasure in sharing some of my knowledge with the osteoid family of endodontics. Custom cast, post, and core. I call it as a tympan treatment plan. Why I call it as a tympan treatment plan? Come, let's meet our patient, Mr. Mohan. Mr. Mohan came to a department with the request of treating the front two teeth and fixing his aesthetics. If you look at the oral cavity, there are many teeth that are missing, and the tooth is grossly mutilated and lower. You can see the incisors that are grossly attenuated. So it gives a picture of a collapsed bite. And in the era of implants, the possible treatment plan for this one could be, it should be replaced by the implant. But however, when we made a radiograph, we saw one was treated with the custom post and core, and he told us this was done in a department 8 years back, and it is perfectly fine. So his request was to do the similar treatment plan for this one also. So looking at the success rate and complete thorough periapical healthy structures and functioning of the tooth, we decided that one also can be treated with the custom cast, post, and core, because we believe that natural tooth is the ultimate implant, and I hope all of you also agree. So friends, at this juncture, I want to thank Dr. Mahalakshmi and Dr. Rajkumar and the team SRM to give me this opportunity of sharing my experience about this topic, because when I started my preparations, I got to know so many facts and the knowledge about this custom cast, post, and core. And I felt that in some cases, it could be the only treatment of choice. And custom cast, post, and core has got a very old history, and it has its own track record, and it has its own charm and grace. So at the end of my presentation, I would like to leave you all for your own perception regarding this custom cast, post, and core. That's why the presentation is on custom cast, post, and core for your eyes only. This is the first exercise in the clinical practical examinations for MDS exams. So the first case is on, the custom cast, post, and core. So we are supposed to discuss the diagnosis, treatment planning about this case, and then we are supposed to see the clinical procedures of tooth preparation, direct wax pattern, casting, cementation, and retraction, and elastomeric impression. Hence, I have the components of my presentations involve case evaluation, post-pace preparation, tooth preparation for post, core, and crown, canal impression evaluation, casting evaluation, evaluation of the fitting of the casting, cementation of the post and core, and gingival management and impression. So friends, when we want to do some treatment for any organ in the body, we are supposed to know how it functions. So let's see what are the biomechanics of anterior teeth. We all know the anterior teeth are separated by overbite and overjet of 2 mm in normal occlusion. And let's see how these teeth function and what are the stress-bearing areas. So if you look at the stress distribution across the root in the tooth, let's take the upper anterior, because that is the exam exercise, and usually the students will be working on a central incisor. So F is the force applied on the lingual surface of the tooth. So now when the anterior teeth, when that, in normal occlusion, they're separated, when the mandible move forward, and in the excursive movements, the palatal surfaces are going to be the area of load. So when the force is applied onto the lingual surface, the fulcrum is on the buccal surface that corresponds to the alveolar crest. So at the alveolar crest, the fulcrum acts. And at the loading area, there will be tensile stresses, that is T. And at the non-loading area, there will be compressive stresses. Friends, I want all of you to remember these points, because the most of our presentation will be evolving around this. And but there are many other structures, important components of a central incisor, which is going to give it the structural durability. So one of these areas, let us look at that.
So the junction between the clinical crown and the clinical root, that is at the neck of the tooth, C junction, it bears the shear stresses, tension on the loading and the compression on the non-loading side. Moving on to the cingulum, the concavity, the lingual concavity in the upper anterior teeth bears compressive stress during centric occlusion, tensile and shear stresses during protrusive mandibular movements. Now moving on to the axial line angles. So we have the axial line angles and the lingual ridges. These are going to bear the shear stresses on loading, tensile stresses, and on non-loading side, compressive stresses. And the important one is the incisal edge. This bears the tensile and the shear stresses in normal occlusion. So again, we need to remember all these important factors about the stress-bearing areas in the anterior tooth, because when any of these or more of these are lost, then the treatment plan for the central incisor changes. This was also proved in a finite element analysis, where you can see there is a maximum amount of load on the incisal edges, and on the stress-bearing area there is a load, and some load is also seen on the labial surface, and maximum load is on the lingual surface at the C junction. So this was found on a finite element analysis. Now, such a tooth, if it gets so much mutilated, could be because of trauma or because of caries, then the rehabilitation of such grossly mutilated teeth becomes a real challenge for us. So in such cases, we usually recommend the custom post and core for that matter. So what is the ultimate goal of post and core retained crowns? The interradicular retainer must comply and optimize the biological properties, its relation between the soft tissues and in and around, and mechanical factors. It should bear the occlusal masticatory load and other load during whenever it is in function, and it is supposed to give the maximum aesthetics because anterior is the aesthetic zone. So these factors are supposed to be given by the post and core retained crowns. So the length and strength and longevity of the restoration depends upon many factors. Post factors, if you consider what material it is made up of, the dimensions, post length and the diameter, the length of the root, the thickness of the root dentin, remaining coronal tooth structure and presence of a ferrule, what is the bond between the post and the dentin and the load on the tooth. So considering all these things, I have divided my presentations into a few containers. The first one is going to be the diagnosis and treatment planning, the tooth preparation, wax pattern, cementation, and gingival management and impression. So friends, let's move on to my presentation. So the first container is going to be the diagnosis and treatment planning. So we should look at the clinical scenario pre-operatively. What are the factors to be considered? We are going to discuss now. So the dental and medical history has to be taken. The student is supposed to have taken all this history, and we are supposed to discuss with the students regarding that. So what are the dental history and what are the medical histories? What are the relative contraindications? And if any medical history is there, and how to take care of that before starting the treatment plan, the student is supposed to discuss with us. And why was the case selected for custom cast post and core? What is the quality of root canal treatment? What is the periapical index? What is the timing for the post-place preparation? What is the armamentarium that he has used? And also, what are the factors affecting the prognosis of the post-retained tooth have to be discussed. So the diagnosis and treatment planning, in that the student is supposed to give us the diagnosis of the periapical area, and if there is a trauma involved, and the diagnosis of trauma according to American Association of Endodontics. And if the post-treatment is done, after the post-endodontic treatment, has the periapical in the lesion, has it regressed, or is it in healing period or not? And what is the need for the post-retained crown? All these things have to be discussed during the diagnosis and treatment planning. So as we all know, the various diagnostic terminologies as per AAE are asymptomatic erosive pulpitis, pulp necrosis, previously treated tooth, symptomatic apical periodontitis or asymptomatic apical periodontitis, chronic acute apical abscess, condensing osteotitis. And if it is a case of a trauma, then it is going to be the complicated fracture involving enamel and dentin with the pulp exposure. Fine. Once the diagnosis is done, now we have to discuss with the student why the post is indicated in this case. So let's see some of the indications. So the caries, trauma, existing restorations or access with loss of marginal ridges, oblique ridge and roof of the pulp chamber is one of the indication. So friends, I want you to remember this picture as well as this diagram. So whenever any of these stress-bearing areas are lost, more than 50%, then the tooth becomes structurally weak. As well as, look at this tooth. If there is so much of a loss of the tooth structure, how are we going to give an anchorage to the restoration? So insufficient anchorage of restoration in the remaining dental tissue is there. To have a definitive crown restoration, the tooth requires a post. Fine, yeah, the tooth requires a post, but then why did we select the custom cast post and core? So the student is supposed to discuss and justify a statement plan regarding the choice of custom cast post and core. So let's see some of the classic indications of custom cast post and core. So according to Jefferson David et al., little remnant in the crown portion, especially in the height of the cervical region. So if you remember the finite element analysis, the greatest load is on the cervical area at the lingual surface. So if there is less amount of tooth structure, then it's an indication for a custom cast post. And if at all there is any single tooth is moved or luxated during the trauma, then if the patient is not willing to undergo the root canal treatment but desires to have the tooth in alignment, a small change in angulation is possible only with the custom cast post. So in such case, it can be indicated. Also, excessively tapered or elliptical root canals. Usually the maxillary central incisors will have the elliptical root canal. So the root anatomy defines the selection of the intraradicular retainer. And we all know the post should also accommodate the morphology, developmental root depressions, and the curvatures. So definitely it is the custom made post for that particular root. So custom cast post is indicated. Also, the teeth with total crown destruction, where practically only the root remains. So here, the custom cast post is indicated. And how do we justify this? So the stress distribution in dental roots restored with different post and cores was evaluated. So in this finite element analysis were involved. So A is the healthy natural tooth, B is the gold cast metallic post and core, C is the fiberglass post and core, and D is a fiberglass post with a composite resin core. And everywhere we could see that there is a slightly high stress levels on the lingual area, and the gold cast metallic post better performed and a homogeneous stress distribution is observed. There is not much of a red color here because the stress distribution is evenly happening. So the custom cast posts are better in such cases. Also, what is the evidence? So look at the evidence in the form of a systematic review and meta-analysis. So meta-analysis of the data showed that no difference in the fracture behavior associated with the cast and the direct post and core treatment modalities. The survival rate of the cast post and the course in the two studies range from 87 to 88%, and in the third study, at least 86% for direct course after 27 months. But however, there's a caution of note. This systematic review involved both the experimentals in the in vitro studies and some of the case reports, but there are no randomized clinical trials. So they have concluded saying that randomized clinical trials on these topics were not available, but should be conducted to verify the published findings. So we can say in the following clinical scenario, the custom cast post is most preferred. So especially in case of maxillary incisors, because they receive non-axial load. So we all know there is a difference between the load in the posteriors and the anteriors. In the anteriors, the load is going to be non-axial during the function. And teeth with absence of coronal remainder should be considered for the custom cast and core, post and core. And also the patients who are having the parafunctional habits. So the teeth subjected to parafunctional habits are indicated for custom cast, post and core, because normal occlusion, the forces could be around 793 newtons, whereas in case of parafunctional habits, it goes up to 1058 plus or minus 68. So these post and cores require maximum strength. Also in cases where the teeth are involved in occlusal guidance. So we want to change the occlusal scheme. So some of the teeth are required to be modified to get the occlusal guidance. And if these teeth are involved in that, and also if there are going to be the abutment for FPD or removable dentures, they are going to take up the load of the adjacent tooth also. So in such cases, we require a stronger post. they are indicated for custom cast post and core. Why custom cast post and core? Because they can provide the highest strength, around 1000 to 124 newtons, and post can accommodate the morphology. And because it is able to accommodate the morphology, it is going to have a minimal yielding surface, a less weaker junction, and we can have an inherent anti-rotation mechanism. And also there is a possibility of angulated post design with a custom cast post and core. That's why this will be indicated in all the previous cases. So, dear colleagues, let's have a recap of what we have covered so far. When are the custom cast posts preferred? When there is excessive tapered or optical root canals, an abscess of cervical crown ferrule, and the presence of parafunctional habits, it is preferred. And why it is preferred? Because it is having a definitive advantages like higher strength, precise fit accommodating the morphology, leading to minimal yielding surface, inherent anti-rotational mechanism, and possibility of angulated post design. So with this, let's next. So if the tooth had a periapical lesion, we have to see the sequence of the radiographs. The student is supposed to present all the X-rays starting from the preoperative working length master bone and the obturation. And if there is a periapical lesion, there has to be some waiting period. And we have to make sure that there is an apical lesion that is either healing or it is already healed. So that has to be examined in the radiographs. And also, we have to consider the factors affecting the integrity of the apical seal. As some part of the root canal system is going to be occupied by the post, this remaining amount of obturating material should not compromise the apical seal. So the student is supposed to know what are the factors affecting the integrity and what care he has taken to prevent the disturbance of the apical seal. So there are various obturation techniques. The different types of sealers could have been used. The time of the process preparation and the instruments used for Gattapacha removal need to be discussed with the student. So let's see some of the literature. The choice of obturation technique for post and cores was evaluated. Excuse me. Now recently we have most of the commonly used techniques are single cone techniques and continuous wave condensation. So effect of obturation technique with immediate and delayed post space preparation on apical voids of bond strength of apical Gattapacha was evaluated by Long. The percentage volume of voids and bond strength of the apical Gattapacha were similar and they were not significantly different. However, looking at the anatomy of the canal, the preferred technique for maxillary incisor is continuous wave of condensation technique. And the choice of the sealer and the time of the post-space preparation. I do remember my postgraduate exam time, and I have my highest regards to my examiners, that is very famous Dr. Lakshmi Narayan and late Dr. Suresh Chandra Shetty. The humble regards to both of them, and they asked me in the exam what was the choice of my sealer. And that time we all know that zinc oxygenol was the only commonly used root canal sealer. And in that they asked me, do I prefer fast setting or slow setting zinc oxygenol for this case? So friends, this also we are supposed to discuss with the student. And the best time to prepare the post space is determined by the sealer setting time. The post space should be prepared after the complete setting of the sealer is the golden mantra. If nowadays we are using bioceramic sealers, if endoseal, NTA like that bioceramic sealers are used, it has a short setting time and the post-space preparation time doesn't affect the apical microleakage. Whereas if we have used a AH+ like any resin sealers, it has a long setting time and is advisable to delay the post-space preparation as per this article. And what are the methods of removal of GP the student has used? And what are the various techniques that are available we need to discuss? So the mechanical, chemical, and thermal. So the mechanical includes the use of log piezo reamers, gauge gradient burrs, and other types of routine instruments. However, there is a chance that we can end up in the drawbacks are there can be microcracks production or there can be deviation of the canal, transportation of the canal. Chemical use of Gattapacha solvents can be used, but we know that it can form a smear onto the surface of the root dentin, affecting the sealing ability of the post. So thermal are relatively safe because with the heat, we're supposed to remove without compromising the root structure, we can remove the gatapacha, and we have to take care that the temperature doesn't affect the periodontal ligament space. So a study was done by Zuli et al. Post-based preparation with lavopisoremus, gaze-glidden, X-acto, and white post drills, and they reported that they induced damage to at different levels, at 3 mm, 6 mm, 9 mm, 12 mm, different types of, the micro cracks were observed. But however, they concluded that gaze-glidden drills tended to cause fewer root dentin defects than other drills. So gaze-glidden drills can be the choice of instruments. So we have decided the post and we have prepared the post base. Now we want to know what will be the dimension, the length and the diameter of the important dimensions. So let's move on to this dimension.
About
The length of the post. So what are the factors that determine the length of the post? There's a beautiful schematic diagram in the textbook Endodontic Science by Carol Esteta, a beautiful textbook, and I request all of you to definitely read this book. So here it is given that the post length should be equal to the incisor-cervical length of the crown. So the future crown that is going to come onto the tooth will be the length of the crown. Or we can also measure the contralateral length of the crown. That can give us the dimension. Suppose we are working on a 1-1, we can measure the length of the 2-1, and that is going to be the length of the crown. So it is recommended that the post length should be equal to that, at least equal to that of the future crown length. The second concept is the post length should be equal to the 2/3 of the root length. So to have a better retention, it is also recommended, if possible, it can be 2/3 of the root length. And the third concept is post length should reach half the distance between the alveolar crest and the root apex. So it should be at least half or more than that. Why so? Colleagues, do you remember this diagram where I told you the fulcrum of the action of the forces is going to be at the alveolar crest? So it's very important for us to know how much of the root is embedded in the bone, and the post should be also definitely supported by the alveolar bone. So it should extend definitely deeper into the alveolar bone. There was, we can see a reference by Johnson, and they have evaluated the Dowell form and the tensile forces. And they said that if the post length can be 3/4 of the root length, it is going to have an equal stress distribution. And also it can be 24 to 30% more retentive than half the length of the root or the crown height also. So if the root, we have the longer root, then we can also plan for a 3/4 length of the root to have a more retention. So finally, we can say the factors which we have to consider regarding the post length is the post should be having the length of 3/4 of length of the root, and minimum 4 mm of apical. It should be apical to the alveolar crest, and it should be up to the curvature of the root because it's a rigid post. It cannot go into the curvature. So we have to go up to the straight part of the root. So that much of length can be designed. Yes, but having this length, what is its effect on the apical seal? So the relative frequency of periapical lesions in tooth with root canal retained post was evaluated by Thompson. In this retrospective study, they have found that if the GP is less than 3 mm, then there was significantly more apical radiolucencies that were developed. So it is not good for the patients. And some of the in vitro studies showed that 4 mm of apical GP leaked very less. So it can be one of the choice. And however, recently there is a study using the CBCT, the intercanal length of the post. They say that it did not influence the periapical radiolucency when the CBCT was used. So earlier, all studies were using the radiographs, but with the CBCT, it says that this study says that there is not much of a difference. However, looking at the integrate and very, the special anatomy at the root apex, which is very complicated, involving the apical delta and the ramifications, the final verdict could be 4 to 6 mm of apical katapacha should be preserved. Let's move on to the diameter of the post. There are 3 philosophies regarding the dimensions of the post according to Engel. The first one is the conservationist theory, advocates the narrowest diameter of the post. So it is always advisable that whatever the biomechanical preparation is done, that is fine enough. We don't have to enlarge the canal to accommodate the post. Second one is the proportionist theory. They say that the diameter doesn't exceed 1/3 of the root diameter. If you consider the root diameter and the post width should not exceed more than 1/3 of the root diameter. And the third one is the preservationist theory. They say that at least leave 1 mm of sound dentin surrounding the entire post. So this is again beautifully depicted in the endodontic science by Estella. He says it should be 1/3. It should not cross 1/3 of the diameter. And even at the apical part of the post, at least 1 mm of sound dentin should be around the dentin. So only that much should be the diameter of the post. Because the increase the post diameter affects the potential for root fracture by increasing the stress and decreases the resistance to fracture. So the post space preparation should not exceed 1/3 the diameter in the smallest cross section. So the final factors to be considered are the post diameter should be less than 1/3 of the root diameter at the C junction. Post diameter should be at least 2 mm less than the root at the midpoint of the post. Post diameter should be less than 1.5 mm at the root, at the apical end of the root also. So maximum, it is recommended that for central incisors, the post diameter could be 1.7 at the max. So what are the instruments ideal for the preparation? We all know that the wider preparation decreases structural durability. So the student is supposed to tell us what are the instruments he used for preparation of the root canal system. That is the post space. So number 4 piezo reamer corresponding to 1.3 mm diameter. Number 5 gauge glidden with 1.3 mm the diameter. And the number 5 parapost drill will give us a preparation of 1.2 mm diameter. So these are recommended for the preparation of the post space. So influence of the residual dentin thickness, we all know 1 mm should be there after conventional endodontic therapy also. So a study was done to evaluate the influence of post thickness and the material on the fracture strength of the teeth with the reduced coronal structure. And here, the 4 groups were prepared: cast post and core of 2 diameters, 1.5 and 1 mm, glass fiber post of 1.5 and 1 mm, and they finally concluded saying that the root canal space should not be enlarged after endodontic treatment, and maximum of 1.1 mm incisors can be there to prevent the perforation as well as to prevent the fracture of the root. So, dear colleagues, let's have a recap of what we have covered so far. The obturation techniques, the better technique would be warm vertical compaction or continuous wave condensation. Timing of the post space preparation, it depends upon the sealer as soon as the sealer sets, and the instruments used for gattapacha preferably are thermal or gauge glidden drills. And the post diameter should be 1/3 of the root diameter, and very important is 1 mm of sound dentin should be left all over the post. And the post length should be, the post should be at least equal to that of the feature length of the crown. It can be extending 2/3 of the root length. And also we should check that the post length should be more than half from the alveolar crest to the root apex to have a proper bone support. I hope all of you are with me. So next, we'll move on to the tooth preparation. So tooth preparation, some of the factors we need to follow, that is the preservation of the tooth structure, retention and resistance, structural durability, margin integrity, and preservation of the periodontium. So the student is supposed to discuss with us, and we are supposed to ask the students regarding what are the principles he has followed and how is he going to justify his points. So the principle of the tooth preparations, there are around few principles we are supposed to follow. We have to understand the position of the tooth preparation margin in relation to the gingiva and the total introduction in buccolingual and mesodistal planes. How much should be the incisal reduction? What should be the buccal and lingual margin design? How much should be the convergence of the axial walls? What should be the finish line depth? And how should be the continuity of the finish line? And how much should be the labial plane? What is the different planes under which the preparation can be done? So the position of the preparation in relation to the gingival margin, we all very well know that it can be either supragingival, subgingival, or in level with the gingival margin. The margin preparation should produce optimal peripheral seal from restoration to the tooth. This is what is our objective. And if we place the margin subgingivally, then it is difficult to achieve the isolation for the bonding and the luting procedures. So ideally, margins should remain on the enamel because it can give a better bonding and reduce marginal micro leakage. So the margin should be well adapted, not deformed during function, and be accessible for the dentist for finishing and for the patient for cleaning. So we prefer supragingival or at the margin of the gingiva. However, if the tooth is discolored and the amount of remaining tooth structure is very short, then we need to go subgingival to have the better length of the preparation. The total amount of tooth reduction in the buccolingual and mesodistal plane should be at least 1 to 1.5 mm, 1 to 1.2 mm on axial reduction, and approximately 10 to 20 degree of total oclusal convergence should be there. The amount of incisal reduction should be 1.5 millimeter to clear the incisal edge and have to have a better strength in both the centric relation and lateral excursion movements of the mandible. The buccal and lingual margins should be definitely, it can be a modified shoulder and rounded internal angles, or it can also be a chamfer. So tooth reduction for all ceramic crown should be 1 mm of axial reduction. Axial convergence of the angles between the opposing wall should be 6 to 10 degrees. The finish line depth. The clinical success depends upon the adaptation of the restoration. The adaptation can be considered as a marginal as well as internal. The better the adaptation, we have the better success of the restoration. If there is a poor adaptation, then they can lead to the cement dissolution and micro leakage, increased plaque retention, and potentially leading to caries and periodontal disease. And high stress concentrations at the margins and internal surfaces, they can definitely reduce the fracture strength. So the margin adaptation should be very good. And this adaptation is generally determined by measuring the perpendicular distance between the prepared tooth and the internal surface of the restoration at the margin. So the marginal gap should be minimum. To have that, we should use an instrument which can give the rounded shoulders, or we can also do the chamfers, which is advocated by various ceramic systems. So a bird having, the ISO number 806314553 should have, it is having the length of the diamond cutting part is 10.5 mm with the apical diameter of 1.1 and with the coarse grit of 106 to 125 microns of diamond particle size can give us a better preparation. There is a finish line, various finish line designs are there, and there's a systematic review and meta-analysis on this. So there are different finish lines that were advocated by this particular researcher. So one is the shoulder model preparation at 90 degree at the C junction with marginal thickness of 0.5 mm, shoulder preparation. And second one is a chamfer preparation at the C junction with the margin thickness of 0.5. And another concept is that is biologically oriented preparation technique. So this is at the C junction with the margin thickness of 0.5 mm, and BOPTB, it's a preparation similar to BOPT, the positioned 1 mm below the C junction with margin thickness of 0.5 mm. So the first two are called as the vertical preparations, and the last two are called as the horizontal preparation. So this systematic review mentioned that there is no such statistically significant difference between the shoulder and the chamfer preparation. The BOPT and BOPTB, these preparations are indicated whenever we want to have a proper emergence angle from the crown. So in those conditions, we may prefer this type of preparations. But however, the margin design can depend upon the clinical circumstances. So whether we want it to be at the having a shoulder or a chamfer, or we want to have the more, as per the emergence profile, we can go for the biologically oriented preparation techniques. So that is the depth continuity of the finish line. We are supposed to have a continuous finish line all around the tooth in a nicely finished manner, because the margin should be well adapted and should not get deformed during the function. So there are various tips that can be used to get this finishing of the finished lines. And I want to also stress upon the appropriate instruments and the magnification. And there are beautiful ultrasonic tips. So we can use the finishing tips or end cutting tip or the specially designed ultrasonic tips, and the magnification we can really appreciate, and we can produce a beautiful finish line. So the label paint reduction should be done with the various burrs, that is a flattened taper Fisher burr, Glassler 6847016 with the tip diameter 1 mm. The pelleted reduction can be done by 6379023, and the Brussels diamond burr for the finishing is 1.1 mm. Excuse me. Sorry. We also have an important concept, that is the ferrule or the splint effect. What is a ferrule? Ferrule, it's a metal collar that encompasses the coronal structure in 360 degree around the parallel walls of the dentine that extends coronally at the end of the tooth preparation. So it's a definitive restoration that extends at least 1.5 to 2 mm apically to the junction between the core and the remaining dental structure. So a minimum thickness of 1 mm is very essential, and this is going to be between the inner wall of the root canal and the external surface of the tooth preparation, and 1 mm is clinically desirable, and the height of the ferrule should be at least 2 mm. What is the importance of this ferrule? This ferrule, as it is going to encircle the tooth, and it is going to be at the junction between the post core and the crown, it reduces the tendency of post and core to transfer the stresses to the root. Rather, it takes up the load. And because it is going to have a stop here, it is going to prevent a wedging effect. So it may prevent the pushing of the gutta percha, as well as it may prevent the vertical root fractures. There are different concepts and different types of ferrules, namely core ferrule and crown ferrule. So what's a core ferrule? The ferrule created by the overlying crown engaging the tooth structure. So this is the crown that is going to be present onto the porcine core. So this is the ferrule created by this crown. Whereas the core ferrule is going to be the ferrule as a part of the metal core. So here is the part of the cast post and core. So this bevel, this ferrule will be developed by a bevel giving at the orifice entrance. So this is called as a core ferrule, and this is called as core ferrule. And the studies have shown that crown ferrule is superior to the core ferrule in increasing the fracture strength. And we can also have anti-rotational groove or keyway in case of the canals where they are circular. If they're elliptical, that itself is going to act like a anti-rotation mechanism. But if the circular canals are there, we can use 170 L burr, and the groove depth should be 0.6 mm, that is the diameter of the burr, and the groove length should be 4 mm, that is the length of the blades. Where is the location? It should be from the orifice at the greatest bulk of the dentine. So that we can have it as an anti-rotation view. So let's have a recap. The radial shoulder or chamfer should be the best finish line. Axillary reduction of 1 mm is going to give a good retention and resistance. The vertical lingual wall increases the retention resistance, and all the preparation should have the rounded angles. So let's move on to the wax pattern. So when the wax pattern is fabricated, so the student is supposed to tell us what is the choice of this wax. So the type 1 medium wax is used for the direct wax pattern. So student is also supposed to discuss with us regarding the ideal properties of the wax. That is, how much is the ideal burnout residue, how much damage stability this wax is supposed to have, what should be the flow of the wax intraorally, all the factors the student is supposed to discuss with us. And there is another way of impression, taking the impression of the canal is by the resin pattern. So what are the advantages of resin pattern? Once it becomes, hard, or once it sets, we can even trim the pattern to get an ideal dimensions and the shape of the wax pattern. So we are also supposed to discuss with the student about the length of the core. So the length of the core should be 3 mm shorter than the adjacent incisor. It is supposed to have a taper of 6 to 10 degrees, and it is supposed to produce a beautiful labial anatomy as well as a palatal anatomy. Only then it is supposed to, it can give a uniform space for the future crown. Sorry. Also, it is supposed to give us, the student is supposed to discuss about the length of the screw, the diameter of the screw, and the material used for the screw. What is the definition of the screw? What is its function? And also, where is the reservoir that is formed? What is the function of the reservoir? What should be the diameter? There should be a certain distance of 1 mm only from the pattern. And what is the reason for that? All this the student is supposed to discuss with us. And once the post canal impression is taken and the pattern is sent for the casting, we need to take care of the post space. So we should ask the student, how is he going to take care of the canal space and why? In between appointment, the post space should be filled with intracanal medicaments like calcium hydroxide because it can help prevention of communication between the lateral canals and the periodontium. So let's have a recap. So type 1 medium wax with the ideal properties of it should be used for the making the wax pattern. Resin pattern also can be used with its own advantages. What are the core dimensions? We have discussed about the screw. What are the various functions? And what are the importance of the reservoir and the dimensions of the reservoir? This all also we are supposed to discuss with the student. So friends, now let's move on to the casting evaluation and cementation. So what are the various materials that are used for fabricating this custom cast post? Nowadays, contemporary practice involves nickel chromium. So nickel chromium alloys, they have a higher elastic module. Hence, they allow a high amount of stress concentration previous to bending. They take up a lot of load and previous to transmitting the stresses to the tooth. So only they promote a higher failure resistance. And you remember what we discussed in the earlier slides, that where there is a very little amount of tooth structure left to take up the load, then this post and core is indicated with the nickel chrome because it can take up the higher load on its own. And however, there are different alloys that were used. So type 4 gold alloy has its own charm, that it can be well adapted, it is inert and has good mechanical properties. But the downside of that is the color, and it is quite expensive. Whereas the disadvantage of base metals are it is more harder and unstable chemical structure, and manipulation is not very good. Now, before adapting to the canal, the student is supposed to show us or the presenters the casting, and he should have evaluated the casting defects. So we need to discuss with the student regarding any casting defects that are present on the casting and what is the etiology and the prevention of the same. That should be discussed with the student, like incomplete casting, the blebs and the voids or the nodules. All those things have to be discussed. And what is the further treatment for the same? That means if there are casting defects, are we going to accept this by some modification, or do we have to reject it? That clear understanding should be there by the student. And finally, the cementation of the casting and the radiographic evaluation. When the student has adapted the post and core and make a radiograph to check, we need to check the gap between the post and the remaining root canal. It should be 0.5 to 1 mm, because the gap that is wider than 2 mm, the clinical outcome is significantly unfavorable. Why so? Because the gap between the post and the remaining root canal filling leads to the invasion of the microorganisms after the post restoration. So this gap is essential To prevent that, as well as this gap, if it is only 0.5 to 1 mm, can act like a cushioning effect, preventing the wedging of the post. So this is very important. The student should know about this. Moving on to the cementation. So what is the function of the cementing media? The student is supposed to know. It helps in retention, it helps in sealing along the root canal, and it promotes a layer of cushioning to uniform distribution of stress between the post and the root canal wall. What are the various cements? We have a zinc phosphate cement with very good compressive strength of 80 to 110 MPa, tensile strength of 5 to 7 MPa, high modulus of elasticity of 13 GPa, but only thing is it is going to give us a mechanical retention. So the proven reliability of zinc phosphate cement validates its use in long-term luting of well-fitting prefabricated and cast posts both. Now, moving on to the glass enamel, most of the students are very fond of the glass enamels. Yeah, though it gives a high compressive strength of 90 to 230 MPa, it has a disadvantage, that is modulus of elasticity is lower. And also, we all know that it is very susceptible to moisture attack and subsequent solubility. Recently, we all use the resin cements, and it has got good properties like ability to adhere to multiple substrates with high compressive strength. It has resistance to tensile fatigue. It is virtually insoluble in oral environment, and the filler also contributes to the improved marginal wear resistance. And we can have very good shade matching potentialities possible under the all ceramic crowns. So, what does the literature say? The retrospective analysis of survival rates of post and course in a dental school setting was done by Martino et al. And various cements, post-cemented with different cements, were evaluated and other long term. So it's a retrospective study. So they found out that the post-cemented with resin or zinc phosphate cement were significantly more likely to survive compared with those cemented with the glass enamel cement. So moving on to the last part, that is the gingival management and impression. So the student is supposed to give us the various methods of gingival management, that is chemical, mechanical, surgical, electrical, and recently also the laser. So advantages and disadvantages of each of these techniques, and whatever technique he has preferred in his case today, that also should be discussed along with the student. And the impressions, what are the different impression techniques that are available? So are the custom trays better over the stock trays? So whatever he has used today, he needs to justify. The most accurate combination of material, technique, and spacer design was the multiple mix technique for addition silicone when the spacer was closely adapted to the dentulous area according to Kaushik and Damon. Also, we can discuss about the recent advances in the impression. So now the whole dentistry is moving towards the digitalization. So digital workflow, so digital impressions and the complete digital workflow can be discussed along with the student for the completion of the case. So friends, with this, we have discussed all the factors we need to evaluate and discuss during the exams under the following components. The crown cementation is not part of the exam. At least the student should be able to fix the temporary crown for the case. So with this, I would like to conclude my presentation, and let's come together, have a common thinking, and we can evaluate the student with the common objectives and the common parameters so that the examination and the evaluation will be uniform all over. So for that, I thank all of you for giving me an opportunity to share some of my knowledge and experience. And I really thank Dr. Mahalakshmi, Dr. Rajkumar, and the team SRM for giving me this opportunity. And this is the best platform where all of us, all over the pan-India, all of us are going to have a common parameters so that there will not be any discrepancies in the examinations, and we all conduct examination in a similar manner and in a more productive manner. So for this, I thank the team SRM for giving me this opportunity. Thank you, and good afternoon, and have a happy lunch. Thank you.
Thank you, Dr. Girija. That was a very exhaustive and elaborate presentation that you have made.
Thank you. Thank you, Dr. Ramya.
I think
I
we
have
don't
a
have it.
question.
Yeah.
I have a question. Girija,
Yeah.
see, some of our examiners, when they come, they stress upon, some of them, especially the old timers, they stress upon the core ferrule as well as the crown ferrule.
Yeah.
Don't you think we should have some common consensus regarding this? We should now stick only to crown ferrule and not core ferrule at all, because it is very clear that that is not at all required. It is, I mean, it's not so important. When you have enough vertical remaining tooth structure, the core ferrule is not so important. So don't you think we must have some common consensus regarding that, and every one of us should be able to follow the same guidelines?
Yeah, that's very true. But only thing is, whenever there is at the entrance of the canal orifice, if the tooth structure is very thin, then we can just give a bevel to make it strong, as well as it is going to help us prevention of, the over driving of the post inside the canal. But only in some cases. But the consensus should be only the core ferrule that is required.
The crown ferrule that
Yeah, sorry. Only the crown ferrule that is most indicated.
Okay.
Can I add up on this? The core, the ferrule is the overall, three-dimensional, like 360-degree covering of the metal.
Yes.
Now, whatever said and done, if there is no ferrule, no bevel, if it may not be it can be just a butt joint. But you need a definitive margin around the tooth. Now, what happens is, if you don't tell them there's a core ferrule, they don't give a definitive margin. So the wax pattern actually extends beyond the margins. They do not know where exactly the wax pattern should end. So for that, at least for that definitive margin, at least they should have something either as a bevel, if not required, then at least as a butt joint. As Girija was saying.
But wherever I have seen, like some places where I've seen, they make like one definite finish line. For
what they do is they do a step. Actually, they do a step.
Yeah,
they do it as a shoulder preparation, which is not correct. It is just a beveling that has to be done.
Yes.
So the bevel can be a 90-degree if the tooth structure is very less. It can be a 45-degree if the tooth structure is adequate enough. Around 2 millimeters.
Yeah, as Dr. Ramya said, it is actually the plan of the old timers only, because that time custom cast gold was used. So that has a property of, burnishing. So
Exactly.
But with nickel chrome, we don't recommend. It is better to have a butt joint. Or
I also have one more discussion point to be discussed here. Do we need to polish the core or leave it as a matte finish? This is one discussion that we can, have a debate on. Correct. If you want to.
Correct. Yeah.
So what is your opinion on that?
Yeah, it is supposed to be definitely not having a very rough surface, because we need to have a good impression, and then we need to reproduce it in the dye and all those things. But some of the researchers or another group says that it can be a little rough because it can have a mechanical retention as well. But now looking at the resin cements and all those things, we may not require that. So it is better if we have a better friction as well as adhesion. So that can come with the good finish of the core. So that is the better option, to have a bit, okay finishing, so that we can have a good impression and the development of the restoration.
Welcome, Dr. Arvind. So I think today's first session, so elaborate and so perfectly, everything was balanced, because cast post exercise goes over 2 days peak time, and the entire, stretch module was actually split up nicely into boxes, and big boxes, and nicely explained by Dr. Girija. So thank you so much, Dr. Girija, for this wonderful presentation of yours.
Thank you. Thank you so much.
And
we have 2 questions.
Yeah.
Oh, okay. Yeah. Sorry, I didn't realize it. Okay, Ramya, please go ahead.
An attendee, are we going to remove GP? You mentioned to use GP.
I've just got the question. They've asked a question like, do we remove the gutta percha using GG drills or piezo reamer? You have mentioned using GG drills also. So there is some clarity that is needed regarding whether GG drills is better or piezo reamers are better.
Yeah, so the literature says, yeah, as per my, what literature I have gone through, it can be also the GG drill. Both the instruments can be used to remove the GP, but then the better one is going to be the piezo reamer. So that we can think of.
Yeah, maybe piezo for refining the post-phase, GG
exactly.
for removing the GP, and piezo for refining and getting the
Refining the
cylindrical
space.
parallel-sided post-phase.
Yeah.
Okay.
And also we can recommend any of this ready-made post drills. Also, we can just the smallest one, we can just run so that it will remove all the undercuts.
Okay. Okay. And one more question is, why can't we do sectional obturation for post and core?
Definitely, yeah. Actually, one of my PG also has done a study on this using the different section obturation and the complete obturation, and section obturation also with different techniques. So there is no doubt that we can definitely use a section obturation, because that is going to create the space already for the post, and we don't have to intervene again. So there won't be much of the mechanical deviation of the root canal and all those things. So preferably sectional obturation also can be done. But if we get the case which is already been treated by somebody else, then we may have to remove the GP for the post-phase preparation. But preferably, if the student is well versed with, the doctor knows, section obturation is the best one.
Okay.
The only thing they have to be careful is when they do the wax pattern and remove the wax pattern, this obturation should not come along with
Should not, yes, definitely.
That's the only hitch.
Warm vertical compaction so that it is nicely compacted. It doesn't get disturbed.
Yes.
That is the best
With sectional obturation, it's little difficult to obtain that. But obviously, as Dr. Girija said, they can do hybrid technique or the thing where they really condense the apical portion properly. That is one thing which is.
Yeah, and also I just want to add, one of my colleague, he has developed one technique, nick and twist it. So what we can do is we can even mark at that level where we want to, remove the GP, and then we can give a twist and it will get separated. And that will remain as a, good obturation technique also.
Yeah, but Dr. Girija, one thing is with sectional, will you be able to seal the lateral canals and accessory canals? That may be a bit of a problem, isn't it?
The sealer is going to help, Dr. Man, and preferably warm vertical. Then only it can.
So that will be the best way, I think, isn't it?
Bioceramic sealer, and
you're well versed with sectional and you're able to handle it without any problems, then you can go ahead with sectional.
But by the time they come to third year, the PGs will be definitely, well versed with all these things, I suppose so.
Ramya, we have one more question.
Okay.
Yes. Ramya, there's one more.
Yeah. Let me just see. Yeah. This is one more question. Are we supposed to level the oblique crown fracture and post and core during crown preparation? Are you supposed to level if it is an oblique fracture?
This is a very common doubt everyone gets, even our PGs also they get. I prefer always to preserve as much as possible the natural tooth, provided it is strong enough. So if the oblique fracture is there, one part which is, which is not fractured, if it is sufficiently strong enough on its own, then I don't do remove that portion, and we can even incorporate along with the pattern. But if it is thin one, then how do we decide? So this should be at least minimum 2 mm thick to have the occlusal load. If it is lesser than that, then I might as well prefer to, make it flat, and then we can make a pattern over that. If it is sufficiently thick, we will not remove, we can incorporate into the wax pattern.
Okay, thank you so much, both of you, to have really extensive presentation and a good question answer session. Thank you, Dr. Girija and Dr. Ramya, for your wonderful moderation.
Thank you, Maha.
And thank Dr. Ramya so much, because she's one of the authority in, endodontics, and all our students, they really go through her textbooks till now also. So I'm so glad that I'm honored to be, the chair, the moderator.
No, the pleasure is entirely mine, Girija, because you did a very exhaustive and more current literature. You have, focused on the current literature and the current evidence. So there was a lot to learn from your presentation. And
Thank
I
you,
hope all the young teachers will benefit a lot from this.
Yes, thank you so much. Dr. Karthikeyan, please proceed.
Yes, ma'am. Thank you, ma'am.